All right, everyone, let's go ahead and get started. Don't have a whole lot of time, so we'll try to get to as much as we possibly can. I did record. Several voiceovers on. I think it's hypo and hyperthyroidism, and also hypo and parathyroidism. So we're fine with those. But there are some others I didn't do a voiceover on that I hope to go ahead and get through. Hopefully you all can see this image. Does everyone, or can everyone see this image of the pituitary gland?
Yes.
Yes.
All right.
Yes.
All right. So when we think about the sign in. So when we think about the endocrine functions, you realize that the endocrine system, it makes hormones that can control your mood, your growth, growth and development, metabolism, as in your thyroid, organs, and also reproductive organs as well. So they control how your hormones are released. And they send these hormones into your bloodstream so that they can travel to other parts of the body or the target tissue, if you will. So if you take a look at this image here, it is showing you the hypothalamus, which is part of the brain. And then there's some nerves that that actually connects the hypothalamus to the posterior part of the pituitary gland. And so that's what makes the connection between these two, the hypothalamus and the posterior pituitary gland. Now, the posterior pituitary gland handles a couple of hormones, and that is, it controls ADH, or what we call vasopressin. And ADH is anti-diuretic hormone. So when you think about diuretic, we're thinking about people being able to pee, right? But if it's anti-diuretic, it stops you from peeing. It's against diuresis. So just think anti-diuresis. And if you can see here where it says the vasopressin or the ADH, this particular hormone is released, or actually not the hormone, the stimulatory hormone is released from the posterior pituitary gland, and it travels to the kidneys. And it tells the kidneys to hold on to hold on to fluids. All right. And here we have oxytocin that is also released by the posterior pituitary gland, and it affects the breasts as well as, breasts and the uterus. It controls those organs, those distant organs. Let me show you something. So if you look at this image here, you can see that the pituitary gland is located up here in the sella turcica. All right, and this is near the brain, right beneath the brain, right beneath the hypothalamus. But what I want you to see is that even though the pituitary gland is located near the brain, it affects these distant organs that you see here, the breasts, the ovaries, the testes, the adrenal cortex, also the thyroid gland, the kidneys, and also the uterus. And also, I forgot bones, muscles, and other organs and whatnot, even the liver. See someone text me. It was one of you. All right, so I just wanted to give you guys a visual before we start talking about it, and to just give you an example. Well, let me back up. So I talked about the posterior pituitary gland, and we talked about the different hormones that are produced and organs that are affected. All right. Now let's look at the anterior portion or the front portion of the pituitary gland. It's referred to as the anterior pituitary. All right. And so this is the one that handles a slew of hormones. All right. It's what? 1, 2, 3, 4, 5, 6, about 6 stimulatory hormones. And so basically, these hormones these are not the actual hormones, but they stimulate. This is a substance that stimulates. What was that? Somebody just came in. These are stimulatory hormones, and so they actually have to travel to the distant organ in order to make it do something. All right. So in this particular case, let's just take TSH. TSH is your thyroid stimulating hormone. So this would have an impact, this stimulatory hormone would have to travel in the bloodstream to the thyroid gland. Remember, the thyroid gland is a vascular system, so it does have a blood supply. So the stimulatory hormone would travel to that distant organ and stimulate it to produce thyroid hormones. And when you think about thyroid hormones, it controls what? Metabolism. All right. So, and most of you, I'm sure, know that. If you look at ACTH, right? So the pituitary is here, but the stimulatory hormone is carried. It's called ACTH. Is carried to the adrenal cortex in order to produce what? Cortical hormones. These are your mineralocorticoids, that are being controlled or produced. Your cortical hormones, it handles things like stress, for example. Helps your body to handle stress. And also your androgens are produced from this area, this area as well. All right. And then think about the follicle stimulating hormone, which affects the testes and the ovaries. So it influences the testes to produce the hormone, the actual hormone. All right. Now, what's leaving here is not the actual hormone, but it is the stimulatory hormone. It causes the distant organs to produce the actual hormone. In this case, the hormone here is testosterone. All right. But this follicle stimulating hormone also influences the ovaries. And what this does is it produces the actual hormone, estrogen and progesterone. Your prolactin, I believe it's abbreviated PRL, right? This stimulatory hormone will cause the breast to do what? Produce milk, right? And then your growth hormone, or GH is another abbreviation that how we describe growth hormone, but it stimulates the bone, muscle, and other organs, the liver in particular, because somatostatin is produced in the liver, and so that's your growth hormone, and it actually affects growth in part of your, as far as your muscles and your muscles and your bone growth and development. Does anyone have any questions about this image? Kind of self-explanatory, right? When I was an LPN years ago, went to a school down in Miami. There was a gentleman, I think he might be dead now, actually. Anyway, so this gentleman, he was from the Bahamas, and this guy could actually explain things very well. Now, when the teacher explained it, I couldn't understand what they were saying, because this almost comes across as kind of abstract, because you think to yourself, well, the pituitary gland is way up here. Well, how is it affecting these other organs then? And as I just explained to you, the stimulatory hormone uses the blood as a kind of a transport system to transport or to carry these stimulatory hormones to these target organs. And he had a way of explaining this thing, and I guess I had one of those epiphany or moments, So, so sometimes when you guys are talking amongst each other, don't hesitate to use the power of, the fact that you guys have a kind of a similar mindset as students, and you might be able to break it down even better than what I am able to, or communicate it better to each other, or you can even teach each other. All right. So you see this image. I don't know what this is. What is this? All right, so let's go ahead and look at this. Let me come out of this so I can make sure you guys can hear it. Let's see here. So take a listen to this short 28 seconds.
The pituitary is a pea-sized gland that controls the function of most other glands and secretes a variety of hormones, such as growth hormone and thyroid-stimulating hormone. The pituitary itself is controlled by a small brain region called the hypothalamus. Growth hormone regulates bone and muscle growth and physical development.
Well, that was pretty short. And of course, I showed you guys this image. This is the brain, of course, as you can see here. This is the hypothalamus, and this stalk is what we kind of refer to it as. It's a kind of a stalk that is situated beneath the hypothalamus. And remember, the posterior portion produces a couple of hormones, but it is the anterior portion. So if you can remember, the anterior portion creates more hormones, then you know about the other side of that, the posterior portion. All right, so let me go ahead and come out of this. Really nice depiction of how the other organs, target organs, are affected. So let me come out of here so I can share. Yeah, so I can share my desktop with you all. Seems you all are getting kicked out today. All right. Oh. All right, so this is chapter 2 that we're looking at, care of patients with pituitary and adrenal gland problems. All right, so as I mentioned, the pituitary and the adrenal glands, they secrete hormones. And this affects the cellular regulation of the entire body. And of course, this includes the fluid and electrolyte balance. The fluid and electrolyte balance. When we talk about fluid and electrolytes, a part of that would be the hormone ACTH, because when you think about ACTH, think about the hormone aldosterone. Remember, the aldosterone deals with sodium and water, right? Remember the ROS system? When the ROS system kicks in, the aldosterone preserves or conserves sodium in water, and that's what causes the blood pressure to increase. Something we don't want in heart failure patients, but so that's fluid and electrolytes on that part. But also think about the posterior pituitary with the ADH, or antidiuretic hormone, and so that also controls your fluid and electrolytes in that sense, because it affects how the kidneys either hold on to, it affects how it holds on to fluids or water. And we'll talk about that. That's when we get into SIADH, or syndrome of inappropriate antidiuretic hormone, which is a condition where you hold on to a lot of volume. And then we also have a DI, which is opposite of that. And that just talks about it's diabetes insipidus. And these are the patients who are just excreting massive amounts of urine. So we'll talk about that one though. I just wanted to kind of give you an idea here. So too much or too little hormones secreted can affect a person physically as well as psychologically. So when we talk about these hyper and hypo conditions, we're talking about too much of the hormone is being produced. That will also demonstrate signs and symptoms related to that. And we're also talking about a small amount of hormones, or too little, is being produced. So the anterior part of the pituitary gland hormones regulates growth. Remember the growth hormone, metabolism. Remember the TSH, and sexual development. Remember the follicle stimulating hormone that affects the testes and the ovaries. The posterior part of the pituitary gland hormones, it deals with something we call vasopressin. And this is an antidiuretic hormone, or ADH. And remember, antidiuretic, against diuresis. So essentially, quickly here, what it's actually doing is that it sends this hormone to the kidneys, and it causes the kidneys to hold on to fluids instead of excreting the fluids. So that's why we're talking about antidiuretic. All right. Just think about against diuresis or against excretion of urine. And so ADH maintains our fluid and electrolytes as well. The adrenal gland hormones, we're talking about these life-sustaining type of hormones. When this system is impacted, adversely impacted, these patients can actually die, because if you think about your mineral corticoids from the cortex of the adrenal gland, it helps you to handle stress. And we talk about that as well, especially when we talk about the hypo-functioning adrenal gland. Sometimes these patients, keep in mind, they might need lifelong hormone replacement treatment depending on severity of their condition. Here is a depiction of both the anterior and posterior pituitary gland again. And so just remember the anterior part, it produces more. All right, remember that's the hypophysical stalk here. All right, and this is that there's some nerve fibers in here that connects the hypothalamus to the posterior pituitary gland. So just take a look at that. All right. When you think about the hypothalamus, just a quick note here. The hypothalamus also plays, not only is it part of the central nervous system, but it also plays a significant role in the endocrine system as well. Remember the ADH and the oxytocin. So it is responsible for maintaining your body's internal balance, or AKA homeostasis. And in order to do this, the hypothalamus helps to stimulate or inhibit many of your body's key processes, including your heart. It controls your heart, your blood pressure, your body's temperatures. I mean, it does quite a bit. All right, and these are your key objectives here. Go ahead and read that when you get a chance. And these are some additional objectives. There's several of them, so just make sure you take the time and just look at these. Some of these are a bit irrelevant, like the hyperaldosteronism or the pheochromocytoma. Don't pay attention to that. We're not looking at that. I think I may have thought that we were looking at that as a disease condition. All right, and these are some of the priority concepts for this chapter. Obviously, fluid and electrolyte balance, and it is the fluid and electrolyte balance exemplar is for hypercortisolism, which we will talk about. And interrelated concepts in this chapter is cellular regulation. Right, this is what these hormones do. They regulate our cells, or these hormones are required in order to have normal cellular regulation or function. All right, let me get my book. So I'll be referring you guys to certain sections in your book. That's why I tell you guys, you have to do your reading, because if I was to try to list everything that is in your textbook, it would be too much. So I list a few things, and then it's your responsibility to make sure you go back and read the rest. All right. So if you take a look at page 1246, chart 62-1 for information on the anterior pituitary and the posterior pituitary gland hypofunction and associated signs and symptoms.
What chart?
This is chart 62-1 on page 1246.
Thank you.
Sure. And I'm not sure if you guys do this, but if you if you go into your modules and you click on the PowerPoint that we're going over now, you can follow along with the notes. You won't be able to modify the notes, but you can at least see them. May decrease some of your writing, but then some of you like to write anyway because it kind of helps you to remember, so that's fine too. Both hemispheres of the pituitary gland, hemispheres anterior, posterior, are significant, but it is, as I mentioned to you, the anterior portion that has the greatest functions on body systems. The anterior portion secretes hormones in order to maintain homeostasis. And I did provide you all with some definitions of what these different hormones mean or what they do. We're talking about the growth hormone, the TSH hormone that, of course, deals with your thyroid gland. We're talking also about the ACTH hormone. This is also made in the anterior portion. And so this particular hormone is needed for your adrenal glands to work properly, and it helps your body to react to stress. So if this hormone was deficient, then your body wouldn't be able to manage stress very well, and of course it can result in death. So ACTH stimulates release of another hormone that is called cortisol from the cortex, or the outer portion, not the medulla, but the outer portion of the adrenal gland. And this is how we get this particular hormone. We're also looking at the follicle stimulating hormone, as I mentioned, and I want you to read that information that I have here as well. You also have the luteinizing hormone, and this affects males and females. You have the MSH, or melanocyte stimulating hormone, and this deals with your skin, and it protects your skin from the UV rays from the sun, and it also controls appetite. You also have your PRL, or prolactin, which is responsible for milk production and mammary glands within breast tissue. So look at that as well. Now, when we talk about pan meaning all, right? Pan-hypopituitarism. And some of these terms are going to confuse you a bit, so you have to really get a grip on these different ones. So yeah, would have been nice if you guys would have been able to listen to, for example, the hyperthyroidism, because basically with hypopituitarism, we're talking about a number of hormones that are stimulated in particular the anterior part of the pituitary gland, but they're producing, for some reason, that the hormone levels are lower. Could be directly the pituitary gland, or could be their distant organs. But at any rate, when we talk about pan, it's just a number of, or all of the, it can be all, but it usually isn't all. That's really rare. But it's usually maybe a few, more than one a hormone that is affected. So it just deals with more anterior pituitary hormones. As you can see here, it says decreased production of all anterior pituitary hormones. Well, that's rare. So you may have perhaps a couple. The most life-threatening deficiencies, as you see here, is if ACTH, remember the stress hormone I talked about, and TSH, because TSH affects pretty much every body system that you have. That's your thyroid stimulating hormone, metabolism, right? There's also deficiency in your gonadotropins. This is the sex glands. And also the growth hormone stimulates liver to produce somatometins. And this hormone enhances growth activity. So again, when you're talking about pan-hypo, we're talking about a slew of hormones, right, that can be impacted. But like I said, the pan type is rare. You usually find maybe a few of them. All right. When we talk about selective hypopituitarism, there's usually a deficiency of at least one pituitary hormone. All right. Deficiencies in ACTH or the TSH, thyroid stimulating hormone, are the most life-threatening. And why I put here? Because there's a decreased secretion of vital hormones from the adrenal and the thyroid glands. So when you think about ACTH, think about adrenal. When you think about TSH, you're thinking about thyroid. So deficiencies in your LH or your luteinizing hormone and your follicle stimulating hormones prevents stimulation of the gonads to produce sex hormones, which can impact changes or the sexual functions in both men and women. For example, in men, the hormone gonadotropins is decreased. If it is decreased, it is going to lead to testicular failure. And of course, if the testicles fail to produce hormone, what hormone does it produce? Testosterone production is going to be diminished. And if that happens, this can lead to sterility for these patients. The same with women. If there's a decrease in the hormone gonadotropins, it can lead to ovarian failure, which can result in amenorrhea, and also infertility as well. All right. Now, when there are deficiencies in, remember, we're talking about deficiencies now because this is hypo. So use these prefixes to help you to know what is going on. If it's hypo, there's a low production of hormones. If it's hyper, there is high production of hormones. By the way, if you guys download, I think you can download from your end these PowerPoints that I have, and you can download it as a PowerPoint, and you can actually write in the note section at that point. But it's just that when they're in the Google Slide mode, you can't, you can't adjust them. All right, so as we talk about deficiencies in growth hormone, changes, it changes, it leads to changes in tissue growth patterns by a decrease in liver production of the somatomedins. And this substance triggers the growth and they trigger growth, and they also maintain bone, cartilage, and other tissues as well. So if the liver cannot produce enough somatomedins, then your growth hormone or your growth is impacted as well. All right. In addition, growth hormone, let's see, your growth hormone deficiencies result in just basically a reduction in your growth hormone. And so when the liver cannot produce, as I mentioned, the somatomedins, or the tissues the tissues might not be able to respond to this particular hormone. So either way, if the liver can't produce enough of the hormone or the tissues cannot respond to the hormone, either way, you have a problem with growth and development, if you will. All right. So remember, you might either have a problem with the release of a hormone, or even if there's the hormone is being released, and just kind of generally speaking, if the hormone is released, it might be the target organ that cannot respond to the hormone. So either one. But as we delve into different parts of this lecture, we'll talk about where there are problems where it's the target organ that is the problem, or it can be the amount of hormones that are released or lack thereof. Now, for adults, as far as deficiencies in growth hormone, This can change cellular regulation by increasing bone destruction activity, and of course, this can lead to bones that are thinner. Think about thinner bones. Think about osteoporosis. And of course, when your bones are thin, they become more fragile. And when they become more fragile, these patients are prone to falling and sustaining fractures. So whenever you have patients with these conditions, you must instruct your UAP to not handle these patients with the hands, but to handle them with bed sheets, because even handling them with the hands in a kind of a somewhat rough way can cause these bones to break. All right, so these patients are very frail. They have weak bones, and so you want to use sheets in order to avoid injury. Let's see. Let's take a look at this video. I may have already. Let's see. What is this? That's another one I want you to see. Not that one. Maybe this one. All right. Let me go ahead and share this one with you all. It's a 1 minute video, so it won't take too long. Let's see.
Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the hypothalamus and pituitary gland. The hypothalamus is a small region situated directly above the brainstem. It is made up of a collection of nuclei with a variety of functions, but in general, the hypothalamus is involved in controlling the two H's, homeostasis and hormones. Homeostasis is a term used to describe the maintenance of balance or stability in a biological system. The hypothalamus can maintain homeostasis either by exerting direct influence over the autonomic nervous system or by causing the release of hormones. The hypothalamus manipulates hormone release primarily by controlling the pituitary gland. The pituitary gland is a hormone-secreting gland that sits just below the hypothalamus. It is sometimes called the master gland because it not only secretes many extremely important hormones, but it also regulates the activity of other hormone-secreting glands throughout the body. The pituitary gland consists of two lobes, called the anterior and the posterior pituitary. The anterior pituitary is responsible for the release of a number of hormones that have widespread effects throughout the body. They include growth hormone, which is involved with growth, follicle-stimulating hormone, which plays a role in development and reproduction, luteinizing hormone, which is essential to testosterone production and reproduction, adrenocorticotropic hormone, which is involved with the stress and fear responses, thyroid-stimulating hormone, which is important to healthy metabolism, and prolactin, which promotes milk production in females. The release of these hormones is controlled by the hypothalamus, which sends signals in the form of releasing hormones to tell the anterior pituitary when to secrete its hormones. The posterior pituitary also secretes two hormones, but does not synthesize them. Instead, they are synthesized by the hypothalamus and then sent to the posterior pituitary for release into the bloodstream. Oxytocin. Oxytocin has important roles in facilitating childbirth and lactation, but is also thought to have a role in compassion and social bonding. Vasopressin's main functions are to control urine output and regulate blood pressure.
My apology, folks, for the
Grammarly does more.
The low volume. I don't know why. These people, if they're gonna make these videos, they need to use some kind of microphone or something. Jeez, it's not that difficult. All right. So just wanted you all to again get a sense of the functions of the hypothalamus. How it controls the stimulatory hormones in both the anterior and posterior pituitary gland, which in turn impacts these distant organs. So kind of wanted to just go through that again. All right. So let's go ahead and look at the causes, some assessment information for hypopituitarism, and also as far as interprofessional collaborative care, lifelong replacement, hormone replacement therapy, and also androgen therapy for virilization, gynecomastia, which can occur. That's when males have, they grow breasts. And also estrogen and progesterone and also growth hormones. So let's take a look at that. As far as causes of a hypopituitarism, remember when I said that sometimes it could be that the organ of the pituitary itself is the problem. And it can also be the distant organ that is the problem. In this particular case, one of the causes is a tumor that is compressing on the pituitary tissue, thereby destroying it. Because, patients, they develop tumors. And it is that pressure that presses on that pituitary tissue, which can impact that tissue. Primarily, it can also be due to malnutrition, can be a cause, or if someone has rapid loss of body fat, can be another cause. All right. There can also be reduced blood flow to the pituitary gland. Remember, even the pituitary gland has a vascular system, a network of vascular system, and it relies on nutrients, oxygen that blood carries to it. But if a patient has shock or some or severe hypotension, it can lead to a reduction in blood flow to the pituitary gland. And if that happens, hypoxia ensues, and infarction, meaning death of the pituitary gland tissue. And ultimately, if the pituitary gland tissue has infarcted or died, if you will, ultimately it will lead to a decrease in hormone secretion. All right, so the pituitary gland cannot carry out its function. Other causes, when you have patients who come into your healthcare institution with hair trauma, brain tumor, or infection, also radiation. You're trying to radiate one part of the brain because of a tumor, and it affects the pituitary gland, because sometimes it's just not very selective, Although they do use some of these the electron beam therapies that can target more specifically a cancer, but sometimes in these cases, radiation treatment. Excuse me, everyone. All right, sorry about that. So radiation treatment can also destroy the pituitary gland, also surgery of the head and the brain. Sometimes things happen, and the pituitary gland might be destroyed due to the surgery. And also if a patient has AIDS, it can also lead to hypopituitarism as well. So those are your causes. Some patients, pregnant women in particular, may experience postpartum bleeding or hemorrhage. And of course, if you're bleeding, then we're talking about, especially if it's significant, it can lead to pituitary infarction, just like a myocardial infarction. happens because of a lack of blood flow to the cardiac tissue, same thing can happen to your pituitary gland. It can infarct. And so again, when this happens, there's a decrease in hormone secretion. They refer to this as Sheehan's syndrome. And what happens is that the pituitary enlarges during pregnancy. And if a patient, if these women experience hypotension due to the bleeding and shock, it will lead to ischemia and necrosis of the gland. All right, and we've already talked about lifelong hormone replacement therapy as well. All right, before I go any further, does anyone have any questions so far? All right. Stop me at any time if you have a question. All right. So as far as assessment is concerned, take a look at the hypostimulation of hormones. I think I've already told you about that one. All right. So we talked about that one. All right, so the pituitary hypofunctions. So I told you about that already. This tells us about a lot of the signs and symptoms as well. That's why I wanted you to look at that one. What happens when there's a deficiency? For example, when the gonadotropins are impacted in women, they might have breast atrophy. They may have the loss of bone density and also a decrease in libido. There's also a decrease in libido in men, decrease in body hair, impotence. So that's just the sex hormones. As far as growth hormone, these patients can experience pathological fractures. They can have a decrease in muscle strength because remember, these muscles are atrophied. So just take a look at that chart, very important information. So the changes in physical appearance and the target organ function occurs with deficiencies of specific hormones. So it depends on which hormone is deficient. All right, so like if your growth hormone is deficient, then you might see certain physical features that I'll show you all a slide when we look at acromegaly. That has to do with the growth hormone, and so it really depends on which organ is impacted, and that'll tell us about perhaps changes in physical features. All right, now. Neurological signs and symptoms of hypopituitarism, when it is due to a tumor growth, these patients are likely to see visual changes as a first sign of a problem. These patients will have problems with their peripheral vision, or they may have vision loss. They may also have headaches. They can have diplopia or double vision, or they also can have a limited eye movement. And so these are just some things in your differential diagnosis. When we say differential, patient comes in with relatively vague symptoms. And so we talk about differential diagnosis, meaning, well, it can be this, it can be that, or it can be the other, you know. So we kind of narrow it down based on our assessment, the different assessment tools that we use, i.e. X-ray, MRI, CTs, whatever is going on with the patient. So again, just make sure you keep that in memory. As far as neurological signs, vision changes. Now, as far as lab assessment of some pituitary hormones, includes measuring the effects of hormones versus actual hormone levels. So for example, T3 and T4 is used to look at possibly a problem with the thyroid, testosterone, and estradiol from the gonads. So we're looking at certain hormones that pertains to the different aspects of the pituitary gland. So again, like the pituitary, anterior pituitary, influence production of your TSH, the thyroid stimulating hormone. So we just check those levels, maybe sex hormones, and so forth. All right. Now, the pituitary gland, as I mentioned to you when I showed you that picture, it rests in what is called the sella turcica. And if there's a problem, these patients can have an X-ray. An X-ray can give or provide an image. It can show changes like if there's an enlargement of the pituitary gland, if there's erosion, maybe there's a tumor pressing on the gland, causing an erosion, because that's what pressure does, or also calcification. If an MRI or CT scan is performed, it can view the bones as well as soft tissue lesions, if there are lesions that are present. We can also do an angiogram. Angio, we're talking about a vascular system, which can determine if the patient has an aneurysm or some other vascular issue that exists before the patient has surgery. So if there's a problem with the vascular system that is that actually feeds, or its purpose is to feed the pituitary gland with adequate blood, then an angiogram can show a problem, show where there's a problem. All right. Now, patients with the hypopituitarism, we think about the fact that they may require hormone replacement therapy in order to ensure that there's adequate cellular regulation, because without the hormone, cellular regulation, it will be altered or impacted in an adverse way. So hormone replacement therapy, it can be temporary, but in some cases it can be lifelong. With men, we're talking about treatments now, with men, as far as if they are lacking in testosterone, the best route to administer synthetic testosterone is to use either a patch, or it can be given transdermally. All right, so those are some of your best routes. Now, we talk about when you give your male patients this hormone, you want to give it until what we refer to as virilization or the appearance of sex hormones, such as you see an increase in the penile size. They will have greater muscle mass. They will have facial and pubic hair, etc. So when you see these, then then you can back off a bit. But until you see these characteristics appear, then these patients continue to receive the synthetic hormone. And again, the therapy can be lifelong in some cases. Now, to increase fertility, sometimes we might give these patients the growth hormone injection. And the growth hormone is your, what did I say, the growth? I'm sorry, not the growth hormone. If we want to increase your fertility, it's the gonadotropin releasing hormone. So there's an injection for that as well that the patient might be prescribed. Now, if you have a male who has rather prostate cancer, we do not want to give these patients androgen or testosterone type of a treatment. It would be actually avoided in these patients because these hormones, such as your testosterone and what have you, they can lead to tumor growth. All right, the tumor can grow because some cancers, they feed on certain hormones. So you would avoid androgens in these patients with prostate cancer. When patients do receive androgen treatment, some of the side effects is gynecomastia, and this is when males have enlarging breasts. They can also have acne. They can have baldness and also prostate enlargement. When we think about prostate enlargement, we think about BPH, benign prostatic hypertrophy. Women with deficiencies in gonadotropin, they receive hormone replacement therapy combination, and that combination might be estrogen and progesterone. But when these patients receive these hormones, they do then become high risk for development of hypertension, high blood pressure, and also DVTs, deep vein thrombosis, especially those who are taking estrogen, and in particular, if they are smokers, it increases their risk even more. As far as the growth hormone deficiency, the treatment is done with sub-Q human growth hormone, or HGH. So they receive an injection as well. And I also provided you all with a definition here. Androgens, they are crucial for male sexual and reproductive function. They are also responsible for the development of secondary sexual characteristics in men, including facial, body hair growth, changes in the voice. Androgens also affect bone and muscle development as well as metabolism too. So it does has quite a bit of functions. Everyone, if you can be back at 1 p.m., that's about 11 minutes. And we'll pick back up. All right, folks, let's go ahead and get started again. All right, so we are now. For some reason, I have these slides out of order. I don't know how I did that. Anyway, so we just took a look at hypopituitarism. Let me go ahead and start sharing again. Let me come out of this because I have to reshare. Hyperpituitary. All right. Can you all see my slide on where it says hyperpituitarism and it talks about causes?
Yes.
All right, good. Any questions, anyone so far? Right. So I'm trying to go as slow as possible so I can make sure you all really understand it. Because when you start looking at some of the other endocrine issues, it's pretty much the same thing as far as you're looking at the hyper side of it, and then you're looking at the hypo side of it. You know, and so you just see there'll be different characteristics and what have you. Typically seen the opposite signs and symptoms. For example, in hyperthyroidism, you'll see diarrhea, and hypothyroidism, you'll see constipation. So really isn't too difficult. Anyway, so we're now looking at hyperpituitarism, causes, our assessment, information we're talking about, and interprofessional collaborative care as well. We also talk about some of the non-surgical management, such as medications, radiation, and also gamma knife procedure as well. So the most common cause of hyperpituitarism is due to a pituitary adenoma, so a tumor. It can be a benign tumor of one or more tissues within the anterior pituitary gland. All right. So, you know, when we talk about benign, we're talking about non-cancerous, but nevertheless, it is a tumor. And of course, it is these tumors that are causing this hypersecretion of the stimulating hormones. So when these adenomas get larger, as I told you, those tumors can begin to compress brain tissue. And of course, these patients will begin to see neurological changes because it is pressing on the brain, which is part of the neurological system, the central neurological system. And also there will be endocrine issues as well. So some of the signs and symptoms you might see are visual changes. Remember, we talked about the diplopia, which is double vision. The peripheral vision is impacted and so forth. These patients may also have headaches, and they also might have increased intracranial pressure, which is very dangerous. All right. So, for example, the prolactin or PRL secreting tumors are the most common pituitary adenomas. And what they do is they secrete an excessive amount of the prolactin stimulating hormone. When this happens, there is an inhibition, or it inhibits the secretion of gonadotropins and other sex hormones that are found in men and women. All right. And this can result in milk production, a reduction in milk production, also amenorrhea in women, as well as infertility. All right. There's also an overproduction of growth hormone. Remember, the hormones are now being hyper-produced, or there's more of the hormone that is being produced, because we're now talking about hyper and not hypo. So this can actually lead to what we call acromegaly. And I'll show you a picture of that here shortly. Actually, I can show it to you now. So when we're talking about acromegaly, we're talking about these large features. So take a look at this. Look at this woman here. On the left side, she looks normal, but when she developed hyperpituitarism, in particular, the growth hormone, there's an overproduction of growth hormones, and look at the much larger features that is displayed on the right side. It's growth hormone hypersecretion after puberty. So I just wanted to give you a visual of what acromegaly meaning enlarged. We're talking about these enlarged features. All right, so with acromegaly, the onset is going to be gradual. It'll be a slow progression without really any noticeable signs and symptoms. But if we can detect that there's a problem early on, it can prevent irreversible changes that occur in the hands and the feet, as well as the face. So, so it's all about early detection in this respect. Because some of these features, if it goes on too long, then the features are going to be permanent. So that this lady you just saw, the picture on the right will become her new look, if you will, if this problem is not detected sooner. As far as other growth hormone changes, these patients may have increased skeletal thickness. They have a hypertrophy of the skin. Remember, everything is growing. There's also an enlargement of the liver as well as the heart. So the skeletal changes do become permanent, unfortunately, for these patients. When we look at other changes, as far as growth hormone, we think about there can be bone thinning. So essentially what happens is bone cell growth or overgrowth happens very slowly. And so there is a breakdown in joint cartilage. There's a hypertrophy of ligaments. The vocal cords are also impacted as well, and these are pretty common. There is also, because of this enlargement, we have these patients may have a hyperglycemia as well, so they have high blood sugars. All right. Now, with the excessive production of ACTH, there's this overstimulation of the steroidal type of hormones. And so the distant organ that is impacted, as I showed you before, would be your adrenal cortex. And with this, there's going to be this overproduction or excessive production of glucocorticoids, your mineralocorticoids, as well as your androgens. All right. And this leads to a condition referred to as Cushing's disease. And we'll actually be, hopefully we'll be discussing Cushing's disease here shortly, if I can get through these PowerPoints. All right, so again, so when we talk about hyperpituitarism, these can be caused by a benign tumor or adenomas that can affect at least one pituitary cell type. And so this can be caused by problems with the hypothalamus, with an increased production that is releasing these hormones. So just what you need to take away from this is that these benign tumors can cause an increased production of the hormones. And basically these hormones would cause an overstimulation or overproduction of the normal pituitary gland. So I would like you to also take a look at page 1248 and chart 62.2. Remember the other chart on 1246 talks about the hyposecretion, but chart 62.2 talks about hypersecretion. All right. That is seen with overproduction of the anterior pituitary hormones. All right. So whenever you're talking to these patients, and this can be a way to help you to better assess these patients, if these patients have a change in the size of a hat, remember maybe they went from a small size hat, now they have a large size hat. Maybe even a medium size hat. Maybe they wore gloves where they were able to wear a small size glove, and now they require a large size glove because they're growing at a pretty fast rate, abnormally fast rate. Also the shoe size. I mean, these patients might wear a size 7, and now they're up to a 10 or 11 or something like that. And also these patients suffer from fatigue as well. All right. So just think about these questions that you can ask your patients that might point to a problem with your growth hormone. When there are high levels of growth hormone these patients may also complain of backaches. They may also have joint pain due to these bone changes that are occurring. And you always want to ask them about any visual changes and headaches as well, because there could be a tumor that is growing. All right. Now, when patients have increased prolactin levels, they do have sexual difficulty. Women may have menstrual changes. They may also have a decreased in libido, painful intercourse, and there's some additional information for you to look at as well. All right, so with the anterior pituitary hyperfunction, it'll talk about the prolactin levels and what happens. Growth hormone talks about the ACTH or Cushing's disease. These patients, think about some of your patients. I'm not sure with some of you, but if you knew any friends, family members, perhaps even yourselves, when you were taking steroids for whatever reason, maybe asthma or some other condition, and you tend to gain weight. These patients have the kind of a moon facial features, kind of a round features. Excuse me. They also have extremity muscle wasting. So the muscles in the arms and legs begin to waste away And of course, these patients become very weak as a result of that. There's also loss of bone density, which means that they are susceptible to bone fractures. They may develop hypertension because they may be retaining a lot of fluids. Hyperglycemia, high blood sugars, can be seen as well. And you also have the thyroid stimulating hormone. They may be also increased. Remember, we're talking about hyperfunction or hypersecretion. So with the thyroid hormones, you're talking about elevated plasma of thyroid stimulating hormone and thyroid hormone levels. These patients might have weight loss because with hyperthyroidism, patients tend to lose weight because the metabolism is very high. So just make sure you take a look at this chart here. A lot of important information on here as well. So with hyperpituitarism, usually one hormone is going to be produced in excess. But the most common hormones that you might see produced will affect either the prolactin, the ACTH, or the growth hormone. So those are the ones that would be mostly impacted. An MRI would be your best imaging tool to diagnose the hyperpituitarism because it could detect whether there's a tumor that is growing. Remember, an MRI looks at the soft tissue. Also, an X-ray of the skull shows an abnormal sella turcica, that bone structure or a compartment that houses the pituitary. All right. The healthcare provider may also do what they call a suppression testing that can also be used to diagnose hyperpituitarism. I think I'm going to highlight both of these so you all can see that these are connected. All right, so in the notes section, you're going to see where I highlighted these two points here. Talks about suppression testing. For example, when a patient has, we're talking about the growth hormone here. When a patient has increased blood sugars, it will suppress the release of the growth hormone, right? So if your patient has hyperglycemia, then growth hormone would not be released. So what they do is they give a patient, this is a procedure, they give these patients about 100 grams of oral glucose in order to try to raise the blood sugar on demand, if you will. And then they will check serial growth hormone levels. So they'll do a series of, they'll obtain blood samples from the patient to look at their growth hormone levels. If the growth hormone levels,
I found this on the web for Delta.
So that was Siri. Siri's eavesdropping. It might be something to these, what's that other one? Siri and the other one. Anyway, so if the growth hormone levels do not fall below the number of 5 nanograms per milliliter, then there's an abnormality. The patient might have hyperpituitarism. Because remember, when the blood sugars rise, the hormones, the growth hormone is not released or suppresses the release of it. So your growth hormone should not remain high. All right, it should be low. And so if it doesn't fall below a certain number, which is 5 nanograms, then there's an abnormality here. So that's your suppression test that can also help determine or diagnose hyperpituitarism. Let's see, there's slide 8. Slide 8. All right. All right. So let's talk about expected outcomes and interventions, which will involve radiation treatment. It involves medications, in particular medications, and also the gamma knife treatment as well. So the goal is essentially to return the hormones to normal levels. We want to, this is an expected outcome. We want to also decrease the patient's headaches. We want to minimize visual disturbances and also prevent any complications and reverse body changes if possible. So those are our expected outcomes. Make sure I note this for you all to look at. All right. So you want to make sure you reassure patients that treatment might reverse the body changes that are caused by the hyperpituitarism. We hope so. So there are drugs used such as Parlodel and also Dostanex. And these are given in combination with possible surgery and radiation. And these drugs actually stimulate the dopamine receptors that are located in the brain. And this will lead to an inhibition, or it will inhibit the release of the growth hormone as well as prolactin hormone. So this is what these drugs have the ability to do. Ultimately inhibiting the release of growth hormone and prolactin hormone. And again, these can be given in combination with surgery and radiation. And let me back up. They will either get one or the other of these drugs that can be given in combination with the surgery and the radiation. As far as Parlodel side effects, look for orthostatic hypotension. It can cause headaches, nausea, abdominal cramps, as well as constipation. What is important is that you want to make sure you give these medications with meals or snacks. And let me go ahead and highlight that as well. So given with meals and with snacks, whenever you guys are looking at some of these medications, one thing I would always do is try to find out if it's given before meals, with meals, or after meals. That's very important. As well as if it can be given with certain drugs should be avoided when given together, because it can decrease the absorption of the medication. When you give this particular medication, the Parlodel, with snacks or meals, it can help to decrease any GI side effects like nausea, vomiting, and diarrhea, or what have you. So these medications are started at a very low dose, but you do not, if you find out if a patient is pregnant, you want to stop Parlodel. Other drugs that can treat acromegaly, the picture I just showed you, is somatostatin analogs, such as your octreotide, your ionreotide, and also your growth hormone receptor blockers. There's another one, Pegvisomant. If I give these to you guys on your test, I'll make sure I send you a list of what I've selected. Now, so the one, let's see, the medication octreotide, what this does is it inhibits growth hormone release through the negative feedback mechanism. Remember, with the positive feedback loop, you're getting a production, or you're causing an activity to increase. The negative feedback loops kicks in, and it terminates that activity. So in this case, the octreotide, it inhibits the release of growth hormone through negative feedback. So it just causes the negative feedback loop to kick in and stop the production of growth hormone release. And hopefully, again, these patients who develop acromegaly as a result of the growth hormone, hopefully that can subside or cease. This other medication that I talked about, pegbisomat, it blocks hormone receptor activity. And so whenever the hormone on the target organ is blocked, then it blocks the production of that particular hormone. All right. Now, radiation treatment, if these patients receive radiation treatment, the effect will not be immediate. They do not receive any therapeutic, immediate therapeutic effect. It can take years before this actually happens. All right. And this is the Gamma knife procedure, or what they call stereostatic radiation treatment. So just know that any therapeutic changes may take quite some time before it occurs. We also have, we talk about surgery, the pituitary gland, and if it does have a tumor, then we want to, or what would happen is the patients would have it surgically removed. They refer to this as hypophyseectomy. Hypophyseectomy is what the surgery is called. And that is basically removal of the pituitary gland. This is the most common treatment for hyperpituitarism. And if this procedure is performed, any body changes that occurred because of the hypersecretion of these hormones, they can be reversed. Yeah, they can be reversed. So once the surgery, one surgery such as this, the hypophyseectomy is performed, sometimes acromegaly will be irreversible, such as growth that is seen in hands and feet. Sometimes it may not be reversed. So keep that in mind as well, and also as a part of your patient teaching. All right, and these are just some of the causes of hyperpituitarism. There's hormone oversecretion that occurs with pituitary tumors, or hyperplasia. Hyperplasia is just thickening of tissues, just growth of tissue. They're just getting enlarging tissue. There's also genetic considerations and also pituitary adenomas. All right. And we talked about some of that. All right. I have also written here, so when there is an overproduction of the prolactin hormone, this can overproduce the hormone, the growth hormone, and the ACTH hormone as well. And this is when you have an overproduction of the prolactin hormone. When there's an excessive amount of ACTH that is produced, it can also increase secretions of MSH, or the melanocyte hormone. Melanocyte stimulating hormone can increase as far as production as well. You know, one thing I wanted to tell you all, when you're first listening to this stuff initially, don't panic. You don't want to get to the place where you're saying to yourselves, this stuff is crazy, it just doesn't make sense. Just go ahead and just listen. The initial discussion, just listen. Don't try to stress your brain out, because you're not getting it the first time. Because I tell you, sometimes it takes the second or third time before some of us get it. Even with myself, I mean, it might be the second time when I go, oh, yeah, I get that. So just be patient with yourselves. Don't be so hard on yourselves. This is not an easy system necessarily, but certainly not impossible to grasp the concepts and what they mean. So don't panic. You got time. We also look at gigantism, and this is the onset of growth hormone hypersecretion before puberty. All right. So there's an example that I also provided for you. The clinical features of growth hormone access, where there was a young man by the name of Robert Wadlow. They also refer to him as the Alton giant. This individual, they weighed about 9 pounds at birth, which, that's a large enough baby. But once he was born, of course, the patient or this individual grew to about 30 pounds by the time they were 6 months old. 6 months. By his first birthday, the child had grew to about 62 pounds. And at the time of his death, which was at the age of 22, the patient or this individual died. I keep saying patient. The individual died from cellulitis of the feet. But at the time of his death, he was 8 feet 11 inches tall, and he weighed about 475 pounds. So to me, that's pretty skinny, but yet very tall. And I'm sure he still have those enlarged features as well. Probably something you can Google, and they may show you what he actually looked like. I think I may have seen the image rather, years ago. I haven't seen it lately though. But anyway, so that's what happens before puberty. They refer to it as gigantism, oversecretion of growth hormone, GH. And we've already looked at this one. So let's move along. With this image here, this is the surgical management, the hypophysectomy. And this is how it's like it's a transsplenoidal approach, surgical approach to accessing the pituitary gland. And so they go through the nose, and this device is able to reach the pituitary gland and remove it. They can also do a selective adenomectomy, and this leaves normal tissue undisturbed. So they can remove the tumor portion that's causing the problem, but leave the other portion alone, which is good because if you can just remove the disease portion, which might be affecting, let's say, maybe one hormone, then maybe that patient would just have to have that one hormone replacement, as opposed to if you remove the entire pituitary gland, then you have to have a replacement for all of them. All right, and after the surgery, this is what we want to do. We want to monitor their neurological response, see if they've had some damage. We are assessing for postnasal drip. We're elevating the head of bed, assessing nasal drainage, avoiding coughing. We're looking for meningitis because you remember you're manipulating the areas of the meninges as you try to access the pituitary gland. There's hormone replacement therapy we have to consider. We also want these patients to avoid bending and also avoid any straining when they're having a bowel movement. So just think about in the case of the straining to have a bowel movement, these patients will have to be placed on stool softeners. So as far as pre-op teaching, and this is very important part of your nursing responsibilities as well, before the patient actually has the surgery, where you can talk to them and they can engage you and whatnot, we must talk to them about or tell them that they would have nasal packing for about 2 to 3 days after surgery. And so these patients would have to be able to breathe through their mouth, right? We generally take a 4x4 and we bend it over and we place it on the top of their lip and we tape it, kind of like a mustache dressing is what we call it. We place it there under the nose because it acts as a kind of a drip, postnasal drip pad. So it collects all that drainage coming out of the nose from the surgery. And so when these patients have this, they cannot brush their teeth, they can't cough, sneeze, blow their nose, they can't bend forward, because all this will lead to increased intracranial pressure. So these patients must really be taught the expectation post surgery. And you do want to do this in the pre-op period, right? Now, the surgical approach, as I mentioned to you, and as I also showed you, is the transsplenoidal approach. This is a minimally invasive and endoscopic transnasal approach with very small instruments. All right, so this is a minimally invasive procedure, which, you know, they recover a whole lot faster with anytime a patient has a minimally invasive procedure, they tend to recover faster. But if this approach fails and they cannot access the pituitary gland, perhaps because of some structural issue, then the craniotomy, they would have to do a craniotomy. So they have to open up the skull. Take a look at page 1249, chart 62-3 for care after a hypophyseectomy. Remember, removal of the pituitary gland. So this talks about the care of these patients after this procedure. And chart 62-4, it talks about a more focused assessment after this procedure as well. So just looking at the first one, as far as post-op care, monitor the patient's neurological status hourly for the first 24 hours and then every 4 hours. So make sure you take a look at that chart. Really great information there. And also, as far as patients, the more focused assessment who undergo the hypophyseectomy. We're looking at their cardiovascular status. We're assessing their cognition and mental status. We're assessing conditions of the operative site, looking at the drainage for color, clarity, as well as odor. And this is a really important one. We're testing, they're testing clear drainage for the presence of glucose. So if you see glucose, we'll talk about this, but if you see clear drainage and you test it and it does contain glucose, there could be a problem. I believe it can lead to meningitis, but just give me a moment and we'll get to that. We're assessing their neuromuscular status, kidney function, as well as the assessment of understanding and adherence to treatment, especially post-procedure. So take a look at those two charts. As far as surgical management concerns, we want to make sure that we are observing their neurological status, like their vision. We want to check for mental status changes. This can be more of your focus assessment as well. We're assessing level of consciousness and also strength of extremities as we want to assess as well. We also want to observe for diabetes insipidus, and this is when they're just excreting a whole lot of urine. So when the posterior part of the posterior part of the pituitary gland is impacted, they can develop diabetes insipidus. And no, they don't have diabetes with this. Don't know why they call it diabetes insipidus. These patients may also have CSF leakage or cerebrospinal fluid leakage. They can also develop infection, and this is what you're also watching out for, as well as increased intracranial pressure. We want to observe for increased swallowing. So if the patient is swallowing a lot, or there's this postnasal drip, it could be because they're swallowing CSF fluid. So this is something you certainly want to report to the healthcare team. We want to elevate the head of bed as well. Then this is good as far as prevention of increased intracranial pressure as well. We're assessing the postnasal drip for the presence of glucose. Remember that clear fluid, because it might be indicative of a CSF leak. So this is why we want. Glucose is usually found in CSF fluid. Remember, the brain requires a lot of glucose, which is why when patients suffer from hypoglycemia, they become very confused, agitated, because the brain is lacking adequate or sufficient glucose. Anyway, so this is the reason why we want to check the glucose, that clear drainage for sugar or glucose. If you see a light yellow color at the edge of the clear drainage on the dressing, we refer to this as halo sign, right? And again, this indicates CSF leak, something that really has to be reported promptly. These patients can also have persistent headache. This can also be due to a possible CSF fluid leak into the sinus area. And so most CSF leaks can resolve with bed rest, though. And sometimes when patients have a lumbar puncture and they have CSF leak, they may use a patch, a blood patch. But in this case, the healthcare team might order a strict bed rest. We talked about avoiding coughing, because coughing does increase your intracranial pressure. We want to also encourage these patients to perform deep breathing, because this can minimize any kind of pulmonary issues like orthostatic pneumonia, rather, right? Typically, we tell patients to turn, cough, deep breathe in order to prevent any post-op complications. But in this case, they want to avoid coughing, but they can deep breathe. All right. And that can mobilize those secretions in the pulmonary system. We want to also moisturize the lips of these patients, because remember, they are breathing through their mouth. And so the lips and the mouth becomes very dry, and due to mouth breathing. We want to assess for infections such as meningitis. So we're looking for signs and symptoms of headache. We'll be studying meningitis later on. Fever, and also what we call nuchal rigidity. So when these patients take their chin and you tell them to touch their chest wall with their chin, so they have to bend their necks, this causes some kind of meningeal irritation, so they have neck pain. So that can indicate meningitis as well. Again, something to report to the healthcare team. If the entire pituitary gland is removed, lifelong replacement thyroid hormones and glucocorticoids will be required. And I told you that already. If these patients do have to bend down to pick up fallen objects, you should instruct them to bend at the knees in order to lower the body to pick up the object, because this would decrease the risk of increased intracranial pressure. We want to also prevent any straining, which I talked about here already. And so some interventions might be increasing the fiber in the diet. They may be increasing in fluids as well as stool softeners. So that is post-op care. I think we have a continued one as well. All right. I talked about no toothbrushing, and this will go on for about 2 weeks after surgery. There should be frequent mouth care, because if you can't brush your tooth for 2 weeks, can you imagine, right? But these patients, they can floss. Some dentists or dental hygienists will tell you that flossing is more important than brushing, because you're getting all that stuff between your teeth. And also mouth rinses can be performed as well. These patients may have a decrease in the sense of smell that is expected to last approximately 3 to 4 months. So you must instruct them of this so that they don't get so anxious. Vasopressin hormone might be needed also to maintain fluid balance, because if the pituitary gland is removed, then this is another hormone replacement that might be required. If the anterior portion of the pituitary gland is removed, remember that is the portion of the pituitary gland that produces most of your hormones. Replacements will be required, such as cortisol, thyroid, gonadal hormone replacement therapy will be needed. And again, this is lifelong. And these patients are taught to report the return of hyperpituitarism signs and symptoms immediately. So as far as your patient education and treatment, again, this is why you must understand the pathophysiology of these disease conditions, as well as signs and symptoms. So this information must be taught to your patients. And now we get into, even if we don't, well, I got a feeling we'll be able to get to SIADH. The first one here is DI. So let's go ahead and go over that one. So if we can't get to the other one, it's pretty much the opposite, right? So as far as DI, or diabetes insipidus, this is water metabolism. This is a water metabolism problem that is caused by ADH deficiency, all right? So when we're talking about ADH, remember, antidiuretic. It will stop you from excreting urine volume, right? And so, but if there is a deficiency, then you're just dumping massive amounts of urine. And so if you're dumping massive amounts of urine, these patients can become what? Hypotensive, dehydrated, severe dehydration, all right? So anytime you have a patient coming in with some kind of trauma, head trauma, or a patient has surgery or an infection, always be on the lookout when you're looking at their urine bedside drainage bag. And if you look and you know that the patient has not been receiving any kind of diuretics, but that bag is just really full, and I mean almost busting full, always think about DI, especially related to some of these problems that they may have had. Now, either there's going to be, as far as diabetes insipidus, there's going to be a decrease in ADH synthesis. In other words, there's not enough ADH being produced by so maybe the posterior portion of the pituitary gland is not producing enough ADH. Or it could also be that the inability of the kidneys to respond to ADH. So there can be a problem with the receptors located directly on the kidneys. So in this case, there is enough ADH being produced, but the receptors on the kidneys cannot respond to it. So remember, that's what I was telling you guys, that it can be the pituitary gland directly, or it can be the distant organ, a target organ, right? That can be impacted as well. And I suppose it can be both, you know, but certainly either or. So with DI, there's increased excretion of large volumes of urine, and the urine is very dilute because you're just dumping a lot of water, right? And so what is happening is the distal kidney tubules and the collecting ducts. Remember, this is where a certain amount of volume of water is being absorbed, reabsorbed, and whatnot in the collecting tubules, or in this case, the distal and the collecting tubules. And so in this case, these tubules are not absorbing enough water, or they're not absorbing, well, I can go with that statement, not enough water, right? And so this will lead to what we refer to as polyuria, all right? What is that, why they call it diabetes insipidus, the diabetes part of it? Because remember, in diabetes, you know, you have polyuria, polydipsia, and so forth and so on. So maybe that's why they refer to it as that. But anyway, so you have an excessive amount of water through urination. And if you have this excessive amount of urination, again, it leads to not only dehydration, but a disturbance in your fluid and electrolyte. So you have a fluid and electrolyte imbalance, all right? Whenever you have this dehydration from this massive water loss. And so when you have a massive water loss, the urine is very diluted, but the plasma, or within the blood, the plasma osmolarity is increased. It's very concentrated because you don't have much volume, right? So much of your volume is being what? Excreted. This will also cause, or rather, your sodium levels would be increased as well because of this hemo concentration, right? So instead of your sodium levels being between 135 and 145, your sodium levels could be 170, right? Very high. Typically, what happens in this condition, because your blood, your plasma volume is depleted almost, or depleted significantly. And so the plasma osmolarity is pretty high. This will stimulate the thirst mechanism in the, is it the hypothalamus? I'll take a look at that. So anyway, so it makes a patient thirsty, right? And so this will lead to the patient wanting to drink a lot of water. If it's a pretty mild case, perhaps even moderate case, the patient may be able to drink enough water to hydrate, right? And so this can maintain the hydration as long as the patient can drink. But if the patient is not able to drink, then it can lead to severe dehydration and ultimately death, all right? And I'm going to get you guys to look at, well, I guess we got time to go over some of these. So the classifications, there can be one of four reasons why this patient has developed DI. So the primary neurogenic DI type is caused by a defect in the hypothalamus or the pituitary gland. So the hypothalamus or the pituitary gland is directly involved in primary, all right? And so what happens in this, with this particular one, the this is neurogenic, because there's a nephrogenic as well. I don't think all right, so the I guess I can change this. So the primary one would be your neurogenic. All right. So the primary one would be your neurogenic. And so what happens here is there's a lack of ADH production or release. So if you don't release enough ADH, then you won't have that antidiuresis. And if you don't have antidiuresis or against diuresis or against excretion, then these patients will urinate volumes of urine. Then we have the secondary neurogenic diabetes insipidus, and this one would not be caused by, well, there would be no direct involvement of the pituitary gland. But this would be caused by tumors that are within or near the hypothalamus or the pituitary gland. Could be due to head trauma, could be an infectious process, could be brain surgery or metastatic condition. Maybe you have lung cancer and the cancer spread to the portions of the brain, right? So that would be a secondary neurogenic diabetes insipidus. Think about tumors in this regard. I'll go ahead and highlight that one as well. So a tumor in or near. All right. So then we also have the nephrogenic diabetes insipidus. And this is caused by, so the kidneys are not able to respond to the ADH, right? So it could be the receptors on the kidneys that cannot respond to the ADH, as opposed to ADH production and release. This has nothing to do, in this particular case, it has nothing to do with the amount of ADH being released or produced, but more so because the kidneys are just not able to respond. Because remember, the kidneys are the distant organ that when that ADH is released and it travels through the blood system to the kidneys just don't respond. All right. So if there is severe damage to the kidneys, to the tubules and what have you, then they cannot respond to ADH, whatever the cause of the kidney destruction or damage is. Now, remember in DI, they're excreting a lot of urine. And so, but if the kidneys are damaged, then again, so it won't be able to respond to the ADH. But remember, if the kidneys can produce, I guess depending on how severe the damage is, if the kidneys can produce some urine, DI can result still that they can produce enough urine. So these patients can still have diabetes insipidus. You may have some destruction, but not severe enough to where it's not producing enough urine. So they can suffer from significant dehydration as well. Then we have DI resulting from a genetic issue that is responsible for producing the ADH receptors that interfere with the kidney's response to the ADH. So if you have a genetic issue here, then you have these receptors that are not working, basically. So if the receptors are not working, then the ADH cannot do anything with the kidneys, right? There are also drug-related causes that interfere with the kidney's response to ADH, causing DI. Both of those drugs are lithium and also demeclocycline. Demeclocycline. I think that's how you pronounce that, demeclocycline. All right. So as far as assessment is concerned, take a look at page 1250, chart 62-5 for signs and symptoms of DI by system. So this will give you information by systems, such as cardiovascular. You have a hypotension. Remember, these patients are depleted of volume. You have tachycardia because if the blood pressure is too low, then the heart rate is going to increase in order to compensate, try to improve the cardiac output. You also have a hemoconcentration. As far as kidneys, urinary symptoms, you have increased urine output. The urine is dilute, so therefore the urine-specific gravity is going to be very low, right? You have poor skin turgor, severe dehydration, right? And so the skin turgor would be poor. That's how we describe dehydration when we're looking at the skin, poor turgor. And so just go ahead and make sure you read that chart on signs and symptoms by systems. Ask the patient if they've had recent surgery, head trauma, or medications. Shock may ensue if the patient cannot drink enough fluid, so watch out for shock symptoms. Water loss changes the blood and urine tests as well. So these patients may have a 24-hour urine without restricting any fluids and food. And so if they have these tests done, if DI is present, what it will show is 4 liters or greater than 4 liters of urine output during this period. This 24-hour testing period can occur. So what you have is greater than 4 liters of urine output during this period, and this will be greater than the volume that these patients are taking in. So you're taking in so much, but you're putting out massive amounts, more than what you're taking in. Some of these patients may excrete as much as 4 to 30 liters per day. And so again, the urine specific gravity, or the urine is very dilute. And so if you tested the urine specific gravity will be less than 1.005. That's very diluted. Usually the urine specific gravity, I believe, is between 1.005 to about 0.030 or something like that. If you also test the patient's blood, as far as the concentration, we call it or refer to it as serum osmolarity. And that talks about the concentration of dissolved particles and minerals in the blood. That can be very low. Actually, it should be high with diabetes insipidus. I don't know why I have 50 to, well, I guess 50 to 200 would be considered high. So, but it will be high because your blood is more concentrated. You're peeing out most of your volume, and what you are holding on to is more elements or dissolved particles to fluids. So you have a high osmolarity. Oh, I see what they're doing. So with this one, when you read this in my notes, it talks about 50 to 200 and whatever this measurement it is per kilogram. So if you were to look at the serum osmolarity, the range is serum osmolarity. The range for your serum osmolarity is, see if I can pull that up. It is 275 to 295. So if your serum osmolarity is, let's say in this case, in DI is, let's say 320, then you know this patient is high, it has a high osmolarity. They're very concentrated. On the lower end, so you'll see a low serum osmolarity when we talk about SIADH, which is the opposite of DI, syndrome of inappropriate antidiuretic hormone. So in other words, the blood is more diluted with SIADH, but it's more concentrated with with DI, right? Now, one of the ways that we can come up with a serum osmolarity, if we don't have one handy, is that if we know what the patient's sodium level is, and you multiply that times 2, let's say if it's 130, if the sodium level is 130, which is low, but if it's 130 multiplied times 2, that means your serum osmolarity is about 260. And if it's 260, then you're more diluted. All right, so that's just another way to know what the serum osmolarity is. Let's see, where are we? All right, so as far as interventions are concerned, so we're looking at some medications. We're looking at early detection as a way or as an important intervention. For example, early detection of dehydration and maintenance of adequate hydration. So we're looking at their blood pressure. We're looking at their vital signs, basically the vital signs, their skin turgor. So we're doing an assessment. The same, looking at the diabetes insipidus key features. And so these are the things that we're looking at the urine output, are they putting out a whole lot, and so forth and so on. Early detection of dehydration and maintenance of adequate hydration can prevent, of course, this patient really getting worse. There's lifelong vasopressin therapy with a permanent condition. So if the pituitary gland is removed, then they will require vasopressin for life. Teach these patients to weigh themselves daily to identify weight gain. So if they're taking vasopressin and it's working too well, then that's the antidiuretic hormone, then they may not be voiding much. And so they're gaining a lot of weight. Same with the SIADH, you want to weigh your patients because they're retaining a lot of fluids. And so you want to make sure you know what their weight is. So drug treatment, as far as managing DI, the most preferred is that second one, the desmopressin, or they also call it DDAVP. This is a synthetic form of vasopressin, and they give it sublingual. So you place it under the tongue and it absorbs. You don't swallow it, you absorb the medication. It can also be given intranasally, so through the nose, like those meter spray devices rather. So intranasally in metered doses. And so the doses, they may vary depending on severity of the patient's condition, meaning if it's very severe, then more doses will be required. If DI is severe, then these patients will require the IV or the IM type or route because it's faster than the sublingual route. For the nasal spray type, as far as side effects, these patients may develop ulcerations of the mouth, allergies, chest tightness, and also lung inhalation of the spray may occur as well. For patients with side effects or upper respiratory infections, you want to give it orally or sublingual or sub-Q. In the hospital, so the nurse must be able to detect, as I mentioned, dehydration and maintain the hydration. So we're looking at their intake and output. We're checking their urine-specific gravity, and as well as their daily weights. We want to encourage these patients, if they can, to take in a lot of fluids. Ideally, you want the intake to equal the output. You don't want more output and you don't want more output and less intake, in other words. So because then your patients are going towards dehydration, severe dehydration. Monitor IV fluids. Well, when you monitor IV fluid, that goes with your intake part. So your intake and output IV fluids will be a part of the intake portion. Also, polyuria, polydipsia, polyuria, they're urinating a lot. Polydipsia, they're very thirsty. And this may be a signal or sign that they may require more of the DD, AVP, or this desmopressin. So look for that as well in these patients. Drugs for DI, they cause a water retention because remember, that's the antidiuretic hormone. So it could result in fluid overload. And so we're teaching these patients to weigh themselves daily, same scale daily, same time, same amount of clothing. If their weight is greater than 2.2 pounds with water toxicity signs and symptoms, because when they're holding on to water now, then they can develop water toxicity. And so signs and symptoms of water toxicity, persistent headache, acute confusion, because their brains can even swell as well with water toxicity. These patients may also develop nausea and vomiting. And so this is a medical emergency, and these patients must be taken to the ER or call 911. So I know we likely, that's DI, and we likely won't have enough time to go over, well, yeah, actually we can. This is not that much. Well, it's not that much as far as, the patho and whatnot. And I might even stay on a little, well, I can stay on a little longer. Some of you can stay. If you can't, then we'll see you later. I can at least make sure we can cover SIADH. And actually, before I let some of you get off, I just need to show you all some information. So let's go and talk about this here quickly. With SIADH, this is a syndrome of inappropriate antidiuretic hormone, and sometimes you can really get these confused. But vasopressin secretes even when the plasma osmolarity is low or normal. And here we're talking about the feedback mechanism that doesn't function properly. And water is generally retained with this one. And so this results in hyponatremia. Remember with DI is hypernatremia because you're eliminating or excreting volumes of urine. In this case, you're retaining water. And so water to these particles, meaning your salts, sodium in particular, will become more diluted. So there's a decrease in your serum sodium level with this one. So always think about the opposites, right? DI, SIADH, hypothyroidism, hyperthyroidism. So just always think about the opposites, and that can help you. So when the plasma osmolarity is low or normal, it means you have enough fluids on board or you're hydrated well enough. But with SIADH, the negative feedback mechanism is broken. And so although your fluid levels are rising, see, once your fluid level gets to a certain level, the negative feedback loop should kick in and say, no more, stop. But the negative feedback loop appears to be broken. And so therefore that fluid level just continues to rise. Your ADH shouldn't kick in when you have too much fluids on board, because if it doesn't kick in, then you're going to urinate, right? But once it kicks in, if it doesn't turn off, then these patients will hold on to a lot of volume. And so anyway, the negative feedback mechanism is broken in this case, and it will cause vasopressin secretion to occur. All right, that's the antidiuretic hormone. And this is going to lead to ADH production, and which will in turn lead to fluid volume overload because you're not going to be able to diurese. And these patients will have a fluid and electrolyte imbalance. They will have a delusional sodium contents. Now, the increase in blood volume will lead to increased kidney filtration. And so what this will do, because you have enough volume now on board, this will inhibit the release of renin and aldosterone. Because remember, when you don't have enough volume, the renin system kicks in, trying to hold on to volume. In this particular case, you got too much volume now. And so there's no use for the renin system or the ROS system to kick in. And so remember with the ROS system, the aldosterone is what holds on to sodium and water. All right. But in this case, because again, the renin or the renin-aldosterone system or the ROS system is inhibited, you're not going to hold on to sodium, and so you'll have a sodium loss as a result. You'll hold on to the water, right? But you'll lose the sodium in this case. All right. And so what this does is it causes the hyponatremia to become even greater. So in other words, your sodium level becomes even more dilute, meaning the levels go down. All right. And I wrote here, so you can read this, where it talks about, remember, with the ROS system, sodium and water is retained, and it only kicks in when the system detects that there's a decrease in blood flow to the kidneys due to possible volume depletion. But when the body thinks that has more volume than what it actually needs, the ROS system, again, it doesn't kick in. And so then the sodium loss or excretion does occur, further causing lower sodium levels. Take a look at page 1252, table 62-1 for causes. Is that the right one? 1252, table 62-1. So causes as far as CNS disorders, there could be trauma, there could be an infection, tumor, strokes. Even in your stroke patients, you must look for SIADH. So just take a look at that table for some additional information. All right. So let me stop sharing here for a minute because I know some of you have to get off. Let's see. All right. Can you all see my tiles on here? I may have to reshare.
Yes.
Yes.
Oh, you see? Oh, good. All right.
Yes.
So, so this is a lot of information too, folks. I mean, you know, 4.5 hours is just not going to get it. So, thankfully, we have other methods. So, if you go under, I think it's week 5, yeah, endocrine system. These are just the regular PowerPoints here that talks about the thyroid, parathyroid glands. Let's see. What is that the same? That might be the same. So thyroid and parathyroid glands are here. This is what you'll see. So it's we're dealing with hyperthyroidism. There is a voiceover for that. We didn't go over this, of course. Oh, and then you have hypothyroidism. There's a voiceover for that as well. And then you have the hyper and hypo parathyroidism. There's a voiceover for that also. So, so we have that taken care of. I want to say that must be a. This thing is clocking. Let me see. I'm just wondering if that's. I have this in here twice. Oh no. So this is just a regular PowerPoint, what we're going over today. And this is your hyperpituitarism, your hypopituitarism, diabetes insipidus. So this is just a regular PowerPoint slides here, right? Without the voiceover. But there is a voiceover on, well, what I just told you. And if this can stop clocking, we can get to it. All right. So here is the video, YouTube videos on the thyroid and parathyroid disorders, 1 and 2. Right. So take a look at that. I didn't know I had done that already. This actually might be hyperthyroidism instead of. Oh no, it isn't. All right. Oh, maybe so. Wait a minute. All right, so yeah. So this voiceover is on hypothyroidism. I would go ahead and listen to this one as well. I mean, even before I would listen to the other one that talks about hypothyroidism, I think I just recently done that one. And so I think it has a lot of good information. I did do a lot of commentary on it. And so this is a lecture I had done last term. And this dealt with I guess that won't move. All right, pretty much what we were going over today. So this is just a reinforcement of what we already went over. This also deals with parathyroidism. So you have that to look at. It's kind of forwarding. Yeah. All right, so you got that. Just curious about this other one. So part 2. So this is hypopituitarism, so I was able to go over that as well. I think this was a time when the reason I was able to go over more of this is because we started our exams much earlier. But we started the exam during class time, so it just takes away so much time. So yeah, so just go ahead and listen to these voiceovers as well. Let's see. All right, so that's that. Just so you all know, when you're doing your clinicals, whether it be SIM group, which is with me, versus clinical with Professor Wittenkeller, I went ahead and created two links here where you can upload your assignments. All right. Let me stop sharing this for a minute. Just need to go through this because I know some of you have to go. All right, so as far as our next exam, well, actually, it'll be quiz 2. It'll be your second quiz. So 2 exams down, 1 quiz down, a second quiz to go. We're just looking at chapters 62 and 63. This is your textbook here, of course. And these are the conditions we're looking at. There's a voiceover on this one, hyper and hypothyroidism. There's also one on hyper and hypoparathyroidism. There'll be one on this one as well because we went over this in class today, right? You'll have to read this particular one. We may not get to it, but it's not very long at all. So take a look at this information. I have PowerPoints, should be at the end of what we're going over now, this particular PowerPoint presentation. And of course, we're going over these 2 now. The diabetes insipidus, and this is a long one. This is actually the same thing, SIADH, syndrome of inappropriate antidiuretic hormone secretion. So this is what we're going over now. This is all that we're dealing with for the next exam. I will get you the medications as soon as possible before the weekend, so you can work on those. And I'll be sending out your focus sheets as well. And so before I let you all off, does anyone have any questions before you go? Well, I guess you all might be inclined to stand on. I don't know. Anyway, so let's go with it, right? So we're dealing with SIADH, and we're almost done. So let's see. Where's my PowerPoint? All right, so let me know when you can see my PowerPoint here on SIADH. We're looking at assessment, noticing, and SIADH. So this is some important information that you should obtain from your patient, whether there were any recent head trauma. CVA can also cause this condition, tuberculosis or other pulmonary disease, cancer, and all past and current drug use. Remember, some of these drugs can cause this as well. And we also want to look at a decrease in serum sodium levels because they are diluted, right? So as far as early signs and symptoms of SIADH, could be due to fluid retention. Yeah, these symptoms can be due to the fluid retention and also dilutional serum sodium, or what we call a hyponatremia. So you have these symptoms such as GI disturbances. The patient may have such as loss of appetite, nausea and vomiting as well. So these are some of your early signs and symptoms. I think I need to reword that. We want to weigh these patients daily if they have gained, see if they have gained weight. These patients, we want to also provide these patients with, I'm sorry, let me back up. So free water is retained in these patients. Remember, we talked about all the volume that they're holding on to. They're not holding on to the salt, but they're holding on to the free water, that volume. It's more free water. And so, but they do not have dependent edema with this. Even though they have this fluid overload, you won't see dependent edema in these patients. With water retention, again, the sodium levels will be low. And so you have this fluid tends to shift. The fluid shifts tends to affect rather the central nervous system function. And this typically happens when the sodium levels fall below 115 milliequivalents per liter. And so the patients will begin to experience signs and symptoms of lethargy, headache, hostility, etc. They will also have a decrease in deep tendon reflexes. So their neurological system is impacted by the low sodium level. You may also find a full bounding pulses, because anytime you have a fluid overload, I think somebody is trying to come back in. Yeah. Sorry about that. All right. So when the patient has a volume fluid overload, the pulse is bounding, becomes bounding and full. Again, this is due to the increase in volume. And of course, the hypothermia rather. This is due to, these patients will have low temperatures as well, due to the central nervous system dysfunction from all the water that they're holding on to in this case. Water retention, it does lead to decreased urine volume. So when you're doing the intake and output, you will notice that they don't have a lot of output or adequate output. And because they don't have much output of urine, because they're holding on to a lot of that volume, the urine tends to be more concentrated. Remember, with DI, the urine is diluted, right? Because you got all that volume of water, all that free water. In this case, with SIADH, free water is being retained, and therefore you're not urinating as much, and therefore the concentration is much higher. Now, with water retention, the plasma volume will increase, as I mentioned, and the plasma osmolarity is going to be low or less concentrated, because you got more volume to particles. So you have your serum osmolarity might be, let's say, 260, 250, or less than 275, which is, the range is between 275 and 300, I believe. When the sodium levels, when the urine sodium levels are increased, and the specific gravity, it does reflect increased urine concentration. So again, in this case, the urine concentration will be increased because of the fact that you have all that sodium now that is in the urine. So you have a lot of particles to a small amount of volume. Serum sodium levels that are decreased, for example, less than 110, or can be as low as 110, even lower actually, because of the fluid retention and the sodium loss. So you'll see actually more sodium loss in these patients. All This is that hemodilution that we talk about. Let's see, where are we? All right. All right, so this is the last slide here. We're talking about how do we respond? What are our interventions related to SIADH? So we typically have to have fluid restrictions in place, because remember, the more fluids they take, the worse their condition gets because they're already holding on to fluids. We may also give these patients diuretics. I believe the SIADH has to be mild in order to give them diuretics. I think I read that somewhere. We may have to give them hypertonic saline, because remember, their sodium levels are almost like threatening too low. And also the maclocycline is given to these patients as well. We're also monitoring for fluid overload. We want to provide a safe environment for these patients because they can become quite confused. Remember, with the cerebral edema or swelling from all the fluid volume overload, and we are assessing them neurologically as well. So let's see, so we talked about fluid restriction, intake. So these patients might become pretty thirsty. We want to promote water excretion as far as these are some of the outcomes we're looking for. We also want to replace the sodium with, as I mentioned, the hypertonic saline, or 3% saline is what we usually give them. And we want to also interfere with the action of ADH. We don't want the ADH to work too well, because this is why they're holding on to all this volume. So we want to interfere with this action. So medications typically would be used for that. As far as fluid restrictions, this is needed because there's too much fluid too much fluid intake can cause further dilution of the plasma, blood plasma. And so we might do a fluid restriction of about 500 to 1,000 cc's per 24-hour period. We want to also dilute the tube feeding bag with saline solution. If you have to give these patients, when you're feeding the patient, you want to give them saline solution as opposed to water. All right, because again, we're trying to get their sodium levels back up. We also want to use saline solutions to irrigate the GI tubes. Again, sodium levels are low, so we want to use sodium or saline solutions. And so we also want to mix drugs given through the GI tubes with saline water as well. Again, not free water, because we're trying to increase their sodium levels. We want to do intake and output. We want to weigh the patients daily. If they gain greater than 2.2 pounds or more over several days, this can be a cause for concern. It can lead to even heart failure, believe it or not. These patients will require frequent mouth care. These patients will need drug treatment. They're called vasopressin receptor antagonist. So you want to, in other words, you're blocking the receptor so that ADH does not have an effect on the kidneys. In the sense that you won't be blocking diuresis, but you will be facilitating diuresis in this case. because you want these patients to urinate. They're holding on to too much volume. One of these medications, these antagonists, vasopressin receptor antagonists, is called Vaptans, such as tolvaptan can be given PO. There's also one called Conivaptan. This can be given IV. All right. And also to treat SIADH patients with low sodium in the hospital, these drugs actually promote, well, I should say that these drugs actually treat SIADH, these patients with a low sodium in the hospital. And so what it does is it promotes water loss without the loss of sodium. And that's why these particular medications are so important. You're excreting water, but you're retaining sodium because we need the sodium to increase. These patients might be sitting at 110, 105 sodium levels, which is very dangerous. The tolvaptan, one of these antagonists, has a little black box warning. It causes a rapid increase in sodium levels of greater than 12 milliequivalents per liter in a 24-hour period. So you have to really be watching, monitoring the sodium levels. I mean, we do want the sodium levels to go up, but we don't want it to go up too rapidly. Now, this is associated with CNS, central nervous system demyelinization, which can actually lead to complications and death. All right. And also, if we use this medication for a prolonged period of time, it can lead to liver failure and death as well. So this is a pretty dangerous medication that has to be monitored. The patient has to be monitored closely. Diuretics are used for a limited time with sodium levels that are near normal, or if the patient has heart failure. So if diuretics are to be given, they won't be given for an extended period of time. But remember, the sodium levels will have to be close to normal at this point. Or the patient, if they're exhibiting any heart failure signs and symptoms, we can give the diuretics as well. Otherwise, with diuretics, if you give these patients diuretics and their sodium levels are pretty low already, sodium loss can be significant, and this can also worsen the SIADH. So be careful about your diuretics administration. The other medication, this is actually an antibiotic that can also impact or that can treat SIADH. Dimeclocycline is an antibiotic. Some of these medications, there was some, they were given it to these patients, and they found that it not only did one thing, but it did some other things too. So apparently they discovered, and it was probably an incidental finding, wherein they discovered dimeclocycline can possibly block the effects of the antidiuretic hormone. So, but this particular medication, the oral antibiotic is used for milder cases of SIADH. And see, so I have written here, physiologically, this drug works by reducing the responsiveness of the collecting tubules cells to ADH. So in essence, when this medication is given, remember within the kidneys, the collecting tubules, they would not respond to ADH, antidiuretic hormone. And if it doesn't respond to ADH, you're going to do what? Pee. And that's what you want in these patients. So the use in SIADH, it actually relies on this side effect. So the fact that that the tubules are not responding to ADH is actually a side effect of this medication. So they'll use the medication. The patient doesn't have an infection, but they're using it for its side effects. That can be therapeutic, if that makes sense to you all. So demeclocycline, it actually induces the nephrogenic diabetes insipidus. It brings about a diabetes insipidus. Remember we talked about the nephrogenic diabetes insipidus? Well, this particular medication will bring that about. Because remember with GI, you're excreting a loss of urine, which is what you want to do in this particular case. It's kind of weird when you think about it, but you're using this medication to bring about the opposite of SIADH. You're trying to bring about a DI temporarily and carefully until you get that volume overload under control. All right. And of course, this can lead to dehydration due to the inability to concentrate their urine. So watch for dehydration in these patients. I did tell you about hypertonic solutions, 3% saline, sodium chloride. This is for patients with very low sodium levels. So we want to give it very slowly due to the fact that it might worsen heart failure and fluid overload. Remember, wherever sodium goes, salt goes. So you always want to watch your sodium levels. You're monitoring them very closely. Saline is always better in IV fluids rather than water solution because the latter or the water solution can add, the water itself can actually cause this, a kind of a sodium dilution, and that's not what you want. So preferably you want to give the saline solution. And this 3% saline, they don't come in these really large bags. They come in the really smaller bags. And so maybe that's a safety mechanism, I don't know, but they're really small bags and they tend to increase the sodium levels pretty high because the concentration is pretty high. All right, so any patient can be at risk for pulmonary edema or heart failure. So we certainly want to prevent any fluid overload. This is especially true in older patients with a history of cardiac disease, renal disease, pulmonary and liver issues as well. When you think about fluid overload, think about signs and symptoms such as a bounding pulse because of all that volume, increased neck vein distension, so JVD. We want to assess their lungs because these patients have crackles in the lungs. They have shortness of breath with increasing peripheral edema. They also have a decreased urine output as well. So we want to monitor the urine output every 2 hours because this can actually occur pretty fast. So we want to watch them very frequently. These patients will probably be in the ICU. As far as a safe environment, due to neurological changes, because of the fact that you have this osmotic fluid shift into the brain, tissue causing cerebral edema, and also the sodium levels that are now also falling, these patients are prone to developing seizures and changes in mental status can occur. So safety is very important. Padding your beds, keeping the patients on bed rest. Other neurological signs and symptoms, they might be muscle twitching, irritability, restlessness, seizures, or coma. So we want to observe these changes again every 2 hours. We want to also decrease environmental noise. Lighting also is reduced in order to avoid overstimulation, over neurological stimulation. So a room that is dark, the light is dim, quiet, because we want to induce more or induce less stimulation. So the more severe the SIADH, the more frequent the neurological assessments should be, because again, these patients, they can have their neurological system can deteriorate rather quickly. And so in your facilities, especially, well, of course, on your computers that you're using, you'll be working with these electronic flow sheets. So make sure you're always looking for trends, any possible problems when you're looking at your patients. So in other words, you might see the heart rate just kind of keep going up, or the blood pressure just keeps going up, so always look at your trends. They're very important. And of course, make sure your side rails, ensure that your bed rails are up for safety for your patient, and make sure you pad them as well. All right, so this is information that I've already provided for you in the form of the PowerPoint notes. So go ahead and look at your adrenal gland hypofunction. They call it Addison's disease. Acute adrenal insufficiency, Addisonian crisis. Again, you do have quite a bit of notes on this. And then you have the adrenal gland hyperfunction. Don't think there's a lot on that either. Yeah, pretty short stuff, actually. And I'll probably end up doing a PowerPoint presentation on this as well as a voiceover because, just because. You just never know. And you're going to stop right there. There's some additional slides beyond that, but you don't have to worry about that. We're not looking at that. Let's see. I think, folks, that is about it. How many people I got? One person? Well, I got Mr. Wolf still on, Miss Emmerich, Miss Flowers, Miss Kendra. All right. All right, so that's it. Do you guys have anything that you want to discuss? So how did you all feel about the exam? Ms. Kendra, are you putting your hand over your head like, oh, brother?
I don't think you can see it.
Yeah, I see that hand on that head. Was it that bad?
It wasn't, I just, I have index cards. I just studied not the correct information.
You studied incorrect information?
Yeah, hold on. Okay, like the lab findings for UTI. I studied, obviously the high white blood cell count.
Why do I see your head, the top of your head? There you go. If you're gonna talk to me, let me see your mouth. Go ahead now.
So I just had a whole bunch of index cards that didn't mean anything.
What did you study?
I studied the right chapter, and I did the